Hello and welcome to IOL in a Nutshell, a series of bite-sized episodes of experienced healthcare professionals sharing their best tips and advice on a range of IOL topics to help you make a difference in your hospital. First off, we need to share a quick disclaimer as the information provided by participants is based on their clinical experience and judgment and may not be endorsed by Medicem Technology, who are the manufacturers of Dilapan-S. Today's topic is about patient choice in the context of labour induction. We look at how factors such as the way we discuss methods with women and birthing people, their past birth experiences, and the practical experience of the healthcare professionals looking after them can all significantly impact choice. The content of this episode is brought to you from a Dilapan-S peer sharing event, where midwives and obstetricians come together to share ideas and advice on a variety of induction of labour related topics. In this episode, they discuss different methods and how they can each impact the birth experience and how to counsel women and birthing people on their options to help them make the right choice for them. So let's get into it.
Anything else to add about patient choice at all? I'm wondering if anybody is able to discuss about what the main reason is that patients don't choose Dilapan.
I'm not completely sure if this is the right area, but in terms of when I've been ringing patients specifically for outpatient induction for not everybody, so it is only the ones eligible for that. Again, I think I echo a lot of what Vicky had said at our unit, that we tend to find that because ProPass and Prostin have been used a very long time, it's the midwifery culture on how they describe induction options, and Dilapan always seems to be like if you've had a failed Prostin or ProPass cycle, then you would then be offered Dilapan, whereas we do need to start bringing these in as our first line. When calling patients up and talking them about outpatient induction and obviously it's only mechanical methods, they've talked about they want to go into labour or they've been induced before and they're worried of being at home and having stuff happen, whereas that is far, far less common with something like Dilapan that doesn't have any stimulation as much as Prostin or ProPass. So for them, it was a familiarity with a process that they had already had, or possibly the way that their induction had been explained to them prior to that. And I think people are almost more comfortable with having a medicine inserted because they're very, very used to taking medicines or tablets, pessaries, etc. Whereas having something put in their body and left there, sometimes I think getting around that was a little bit new to patients when explaining it to them. And from our matron's perspective, one of her questions when we were sort of talking about this was she was, in terms of doing our pre-implementation audit, there was quite a number that I was noticing that would have hyperstimulation, that would go into labour by themselves, so they weren't having to wait for ARMs. They weren't having to go onto an ARM list, and we weren't having to manage that because they were just starting to contract, found to be in labour, transferred around to our labour ward. Whereas that won't happen with Dilapan as well. So it's a different mindset for the ward in terms of managing an ARM list and prioritising those patients that aren't making those decisions for us. So I'd just be interested in what other departments have used, and obviously those that have changed it to first line. That's definitely what our consultant wants to do and would champion that. But I feel I would need to, implement some change techniques to support the mindsets of the women and, well, not the women's, but the staff that are talking to women about induction or counselling them on their options, to also make them feel a bit more comfortable with that.
Absolutely. You brought up some really fantastic points there. I've just noticed that Bob's turned up. Thank you so much for joining us, Bob. Wondering if you might be able to answer some of Kirsty's questions. Sorry to pick on you as soon as you've arrived. We're just talking a little bit about sort of patient choice and changing that sort of midwifery culture and how sort of the audits can really support you with that. I wondered if there was any sort of insight that you had in terms of the implementation of Dilapan within your trust and how you managed to shift that culture.
Here we offer Dilapan as the first choice, the culture here, we ruled it out firstly as it's the first line that we have. And when we've looked at, we did audits first of all, and how women reacted for having the Dilapan and those that we give prostaglandins to, and pain relief being offered. And also when we had newly qualified midwives who had never given prostaglandin in the first place, and they'd only been given Dilapan, and midwives who had given prostaglandins and given Dilapan. And the notable difference that you had is that midwife who had given prostaglandins recognize that when you give only Dilapan and when you'd given prostaglandin in the past, at nighttime and during the daytime, when patients were not asking for pain relief, there was a noticeable difference. And after you've given Dilapan, the initial discomfort that you may have had when you've put Dilapan in, and some women don't get any discomfort at all when you put Dilapan in, there was a noticeable difference there. And when women get Dilapan and they go off home and they come back in their own, when they go in their own space and they come back, there's a noticeable difference there also. And midwives who have never given prostaglandins, in some instance, when they give prostaglandin here, they tell you, oh, I've never seen a mother in so much distress from giving prostaglandin, because they've never seen a mother being in distress because they've only given Dilapan, and when they've seen the prostaglandin that you've given. So that has changed the mindset and the culture. So they will always offer Dilapan non-hormonal as opposed to the prostaglandin. So that changes the mindset. And once Dilapan is put into the cervix and is done properly and people are properly trained, you will always get a cervix that is dilated, as opposed to, if it's not gone into the right spot. And the mothers who've had Dilapan inserted will tell you that they usually suffer no discomfort after the Dilapan has been inserted. So it's the mindset. And if midwives, you come from a midwifery point of view, that it is midwifery that you're doing, tell women to mobilize and you do all the things that you would do as a midwife when you're doing a vaginal examination. That changes the mindset, because you don't need anybody to prescribe. So you get along doing the jobs that you would normally do, and you are being with women. That helps to change the mindset.
Brilliant. Thank you so much, Bob. I'm just wondering if anybody has any thoughts about training sort of community midwives. I do have some sort of suggestions myself, but I'm just wondering if anybody has already gone about sort of training the community midwives so that they feel really confident when discussing induction, Dilapan induction with the women.
We had, in terms of, again, with the outpatient induction, although not training them to physically insert in terms of using the simulation model, they were all encouraged and reminded to sort of watch the presentations that you guys have available, so that they can properly counsel them on what the experience will be like for when they have that. But in terms of, because it's so new, we literally launched it on the 5th of August in terms of having the information back and the feedback about that. But I've been mostly walking around to our low risk birth centre and catching the community midwives and just asking how confident they feel in talking about generally outpatient induction and the non-hormonal methods. Mm-hmm. And I'm slowly starting to get more people say that they don't need the information anymore. So again, we're still trying to embed.
Yeah, absolutely. Still very early stages. Rasheen, did you have something to ask?
No, just to add, we've in our induction of labour leaflet, Dilapan is in there. So when we're discussing induction with our women, we'll speak to them about Dilapan and ProPES, so they're aware of both kind of methods of induction. Obviously, women that are VBACs will just have Dilapan, but our doctors are also very good at counselling women regarding using Dilapan as well. So it's kind of ingrained. Our community staff do it constantly. It's kind of ingrained into our system now that we talk about Dilapan as your first method of induction and then explain ProPES, and a lot of women will have had ProPES before, but then will say, oh yeah, that made me contract and I was really uncomfortable, or that made me, some of them, yes, it makes them labour and they want to have that again because they know that it worked before, and that's absolutely fine. But a lot of them will prefer the Dilapan over ProPES because of the unlikelihood of having hyperstimulation and any kind of adverse effects on their induction and baby, really.
Absolutely. Yeah, you brought up some good point as well about sort of the patient information leaflet. So lots of hospitals do integrate Dilapan into their patient information leaflets once they are happy and they've finished trialling. We also have our own sort of in-house made ones. So if anybody doesn't have access to that and would like it, then please do let us know. And as Annie mentioned already, there is a QR code at the back of that information leaflet in which people can scan, and that sends them through to a patient feedback survey as well. Now, in terms of your community midwives, one suggestion is that because they won't be necessarily doing the insertions themselves, we do offer now training webinars monthly. So if you have noticed that actually a lot of your women are coming in not aware about Dilapan, or, you know, the community midwives are reporting back that they're not feeling very confident discussing it, then please do signpost them over to our training webinars, which again, like I said, sort of happen monthly. And those can be really, really helpful just to even refresh if they haven't spoken about Dilapan in a while.
That's all for today's episode of IOL in a nutshell. We hope you enjoyed hearing from other healthcare professionals and learned something new. Thank you for listening, and if you have any questions or require any clinical support with Dilapan-S in your hospital, please get in touch with us at dilapan.com. Join us next time and have a great day.